What is this disease? This patient is a chronic smoker. Ultimately, this is what is happening to his lungs. What is this smoking related lung disease? COPD, chronic obstructive pulmonary disease. Already I have discussed in detail what will be the difference between asthma and COPD. Let us see COPD in detail. COPD generally has two subtypes. The subtypes are chronic bronchitis and emphysema. Let us see the definitions, then I will tell you whether to use these terminologies yes or no. Chronic bronchitis is cough with expectoration, cough with expectoration for more than 3 months in 2 consecutive years, associated with mucus gland enlargement, whereas emphysema is destruction distal to terminal bronchiole. What is present distal to terminal bronchiole? It is acinus. Now, according to new guidelines, let it be chronic bronchitis or emphysema, it should be called as the COPD only. Now, we are not using chronic bronchitis and emphysema for clinical purposes. So, for all practical purposes, let it be chronic emphysema, chronic bronchitis or emphysema. It should be called as a single term. What is that single term? COPD, chronic obstructive pulmonary disease. They are only used for pathological purposes. In pathology, you will be seeing chronic bronchitis, emphysema. But in clinical medicine, let it be any type, it should be called as COPD. So, it will be diagnosis of COPD, treatment of COPD. Write down risk factors. What are the risk factors? Most common risk factor will be smoking. Then we have alpha 1 antitrypsin deficiency, a genetic defect called as. What happens in alpha 1 antitrypsin deficiency? It is mediated through chromosome 14. Because it is a genetic disease, there will be family history of COPD. Somebody in the family will be suffering with COPD. Young age onset of COPD. Generally, for a patient to develop COPD, he should smoke for at least 20 years. If he starts smoking at his 20th year, by the time he reaches 40 or 50th year, he develops COPD. Now, here patient's age itself will be 20, but there is COPD. What might be the reason? Since his birth, there is something happening in his body that has been responsible for COPD. What can be that? A genetic defect called as alpha 1 antitrypsin deficiency. Less smoking history but COPD. Patient did not smoke or just started to smoke, but there was COPD. So, it is not due to smoking, it can be due to alpha 1 antitrypsin deficiency. Along with lung involvement, there can also be liver involvement. There can be associated liver disease in alpha 1 antitrypsin deficiency. Apart from this, pollution. We all know about outdoor pollution, but females residing in rural areas also are developing COPD because of indoor pollution. What is that? Exposure to biomass fuel. This smoke, when inhaled, can also result in COPD. Coal exposure will also result in COPD. These are the important risk factors. Already we have discussed the pathophysiology of COPD emphysema previously. You know why there is air trapping, why lung volumes increase, why there is bulla formation, why on the chest x-ray you notice bilateral hyperinflated lung fields, flat diaphragms and also tubular heart. Then we will discuss now the diagnosis of COPD. COPD is an obstructive lung disease. What will be most important for diagnosing an obstructive lung disease? Spirometry. Write down. For diagnosis, we depend on spirometry. Within this spirometry, what do you notice? An obstructive pattern. Obstructive pattern. When do you call it as obstructive pattern? If patient's FEV1 by FVC is less than 0.7. Now asthma is also an obstructive lung disease. How is COPD different? In COPD there will be no significant bronchodilator reversibility. There will be no significant bronchodilator reversibility. You know what is bronchodilator reversibility? Increase in FEV1 more than 12% and 200 ml after inhalation of SABA, short acting beta 2 agonist. For COPD, there is a special staging given by Gold staging. According to this, there are 4 stages of COPD. Stage 1, it is mild COPD. Stage 2, moderate COPD. Stage 3, severe COPD. Stage 4, very severe COPD. Let it be at any stage. The common feature is patient's FEV1 by FVC will be less than 0.7. In all this, FEV1 by FVC will be less than 0.7. Then what basis this classification is done? On the basis of patient's FEV1. In mild disease, patient's FEV1 will be more than or equal to 80% of predicted FEV1 of that given age. It is not 80% of FVC. It is 80% of normal FEV1 of that given age. In stage 2, FEV1 50 to 79% of predicted. FEV1 30 to 49% of predicted. Stage 4, FEV1 less than 30% of predicted. Frequently asked question, which of the following qualifies for very severe COPD? Your answer should be FEV1 less than 30% of predicted. FEV1 less than 30% of predicted. For COPD, previously we were using an old index for prognosis called as Bode index. There is a prognosis index called as Bode index. Nowadays we are not using this commonly, so just to know the variables. What are the variables? B stands for BMI, body mass index. O stands for obstruction by knowing the patient's FEV1. D stands for patient's dyspnea grade. E stands for patient's exercise capacity. This exercise capacity can be known by distance covered by patient in 6-minute walk test. I ask the patient to walk for 6 minutes, then I am going to see how much distance he has covered. B stands for BMI. O stands for obstruction. D stands for dyspnea. E stands for exercise capacity. This is a old index. Nowadays we are not using for routine clinical purposes, but they can ask you what are the variables of Bode index in your exam. Now coming to grades of dyspnea for a respiratory disease. You know that whenever there is a heart disease, there is a grading for dyspnea given by New York Heart Association. This is called as NYHA scale. But whereas for respiratory disease, we are having MMRC grading, Modified Medical Research Council. Let us see the grading of breathlessness, the grading of shortness of breath for respiratory disease. Write down MMRC dyspnea grade. MMRC means Modified Medical Research Council. I have made some animations so that you can understand better. We'll start with grade 1. You can see the patient is doing a sternus exercise, only at that time he is becoming breathless or shortness of breath. Shortness of breath on sternus exercise, nothing to worry about it. Now whereas here, if you see this image, patient is having shortness of breath while climbing stairs. Climbing stairs means walking uphill, or patient is feeling breathless while walking on level ground quickly. So when he is trying to walk quickly, he is getting breathlessness here, shortness of breath. While walking on the steps, he is getting shortness of breath. This phenomena is called as grade 1. Shortness of breath on walking uphill or hurrying on level ground. Then what do you see here? Because of shortness of breath, this patient is walking slowly and cannot catch up with the pace of contemporaries. This is grade 2. Walks slowly than others due to shortness of breath. Now in this image, if you see, patient is just walking for some 100 meters and he is getting breathless. This is grade 3. Shortness of breath on walking for just 100 meters. Shortness of breath on walking for just 100 meters. Then this patient is just standing there, and even at rest he is having breathlessness. What is this phenomena? This is grade 4. Patient will have shortness of breath even at rest. Even while dressing, undressing, patient will have shortness of breath. This is the Modified Medical Research Council grading of dyspnea for respiratory disease. 0 on sternus exercise. 1 walking uphill level ground. 2 walks slowly than others due to shortness of breath. 3 just walking for 100 meters. 4 even while dressing, undressing, and he is unable to leave home. Now whenever I discuss about treatment of COPD, what is the most important intervention in management of COPD? Yes, most important, your answer should be smoking cessation. What is the reason behind that? What exactly is responsible for COPD? Smoking. If patient continuously smokes, there will be continuous smoking related inflammation. This smoking related inflammation will be continuously damaging the lung. So if the patient does not stop smoking, the disease will not stop progressing. That's why most important in management of COPD will be smoking cessation. Write down COPD treatment. COPD treatment, most important will be smoking cessation. Will be smoking cessation. Most important will be smoking cessation. Now I should give some drugs which will decrease his symptoms. I can start bronchodilators. Now which bronchodilators will be more helpful here? Is it short acting or long acting? Generally it is a persistent disease, so long acting bronchodilators will be helpful. We have long acting beta 2 agonist and long acting muscarinic antagonist. Long acting beta 2 agonist, you know, solmetrol, formoterol. Solmetrol, formoterol. Long acting muscarinic antagonist, there is tiotropium, glycopyrronium, Umiclinidium. You have umiclinidium. Whereas recently in the market we have ultra-LABAs, ultra long acting beta 2 agonist. The advantage is once daily dosing. Generally whenever I take solmetrol or formoterol, I have to take twice because the duration of action is only 12 hours. Whereas ultra-LABA duration of action is 24 hours. We have indacaterol, vilanterol, olodaterol. These are the ultra long acting beta 2 agonists. Now if they ask you what is most preferred bronchodilator here, in asthma no doubt it is LABA, whereas in COPD most preferred will be LAMA. Now what is the extra advantage of LAMA? So this LAMA can also decrease, smoking related inflammation because of some indirect mechanism. Studies have shown that there was smoking related inflammation decline with LAMA. So that's why in the exam if they ask you most preferred bronchodilator in COPD, your answer should be LAMA. The reason is LAMA has capacity to decrease smoking related inflammation. Next in the management will be steroids. Steroids can be either given as inhaled form or systemic form, tablets or injection. These systemic steroids are given during acute exacerbation. To decrease the smoking related inflammation, they are given during acute exacerbation. But once a patient recovers from acute exacerbation, he can also develop another exacerbation. To decrease frequency of further exacerbations, this inhaled corticosteroids can be added. Then these patients will be having cough thick sputum. To bring out that sputum, mucolytics will be helpful. Mucolytics such as N-acetylcysteine. Is there any new drug in the management of COPD? Yes. We have PDE4 inhibitor. This PDE4 inhibitor is nothing but roflumilast. Now what is this roflumilast? It is also having anti-inflammatory property. It can also decrease frequency of exacerbation. This roflumilast is having anti-inflammatory property. It can decrease the frequency of exacerbation. Then what is role of antibiotics? In asthma exacerbation, nowhere I have discussed about antibiotics. The reason is whenever infective exacerbations in asthma happens, it is due to virus. Most common is rhinovirus. Rhinovirus is nothing but common cold virus. No need to give any antibiotics against that virus. But in COPD, whenever infective exacerbation happens, it can be due to bacteria. To bring down that bacteria, you need antibiotics. Antibiotics are given during exacerbations, and most common bacteria responsible is H. influenza. Haemophilus influenza. Then once the patient recovers from infection, he can also develop another exacerbation because of another infection. In COPD, we are also giving azithromycin prophylaxis. Azithromycin, not just antibacterial to decrease the frequency of infection, It can also have anti-inflammatory property. It can also decrease the smoking related inflammation. Azithromycin prophylaxis to decrease frequency of exacerbations. To decrease frequency of exacerbations. Now, if the patient develops hypoxemia, this patient requires long-term oxygen therapy. Usually more than 15 hours per day. Points to be noted here. You give for prolonged duration, but what do you give? Low flow oxygen. And what will be your target saturation? It will be only 88 to 92% in COPD. Is there any surgery for COPD? Yes. We have lung volume reduction surgery. Frequently done is a bullectomy. We know that in COPD there are hyperinflated areas called as bullas. These bullas do not take part in gaseous exchange but can apply weight on the diaphragm, not allowing its function properly. When you remove these bullas, the diaphragmatic function can improve. The respiratory mechanics can improve. This bullectomy will improve respiratory mechanics. If everything fails, this patient is a candidate for lung transplant. As of now, most common indication for lung transplant worldwide. First indication is ILD, second will be COPD. Most common indication for lung transplant. Most common indication for lung transplant students. Most common indication is ILD. Second will be COPD. Now, even after educating the patient, majority will not stop smoking. And in one fine day, they come to the emergency department. And during exacerbation, what is the preferred method of mechanical ventilation? Your answer is NIV. So, initially you go for NIV. So, initially you go with NIV. Just 1 minute. During exacerbation, initially we go with NIV. If patient not improving, as a last resort, invasive mechanical ventilation done. But what is the disadvantage? Due to invasive mechanical ventilation, more chances of ventilator associated pneumonia, more chances of pneumothorax, that can increase in mortality. During exacerbation, initially we go for NIV. If not improving, we go for IMV. But what are the disadvantages of IMV? There can be ventilator associated pneumonia, increased chances of pneumothorax, increased chances of mortality. This is one slide that I project in majority of my classes, because this is not just a treatment of COPD, this is how a patient with COPD will progress. Now, if I prescribe bronchodilators, steroids, mucolytics, antibiotics, it will cost him about 5,000 per month. Oxygen can cost him about 50,000. Lung volume reduction surgery can cost him 5 lakhs. Lung transplant can cost him 50 lakhs. Exacerbation can cost him his life. All this can be prevented if he stops 50 rupees on cigarettes every day. So, that is the bottom line. When you stop smoking, the progression of the disease can be avoided. The complications can be avoided. That's why most important is smoking cessation. Now for COPD, there is a new algorithm called as COPD ABCD assessment. COPD ABCD assessment. It is based on a graph. So in this graph, on one side you will have patient's symptoms. So in this graph, on one side you are taking patient symptoms, on other side there will be patient's exacerbation history. Symptoms I am dividing into two. Less symptoms means patient is having shortness of breath in the grades 0 to 1. More symptoms means patient is having shortness of breath MMRC more than equal to 2. Symptoms I have divided into 2. Then exacerbation history. Less exacerbations, more exacerbations. In last 1 year, how many times the patient worsened? Less exacerbation means 0 or 1. Non-severe exacerbation, 0 or 1 non-severe exacerbation. More exacerbations means more than 1, non-severe exacerbation in the last 1 year, or more than or equal to 1 severe exacerbation. When do you call it as a severe exacerbation? When it is responsible for hospital admission. So in this table I have divided patient symptoms into two. Less symptoms, more symptoms. I am drawing a line like this. I have divided patient's exacerbation history in last 1 year into less and more. Again I am drawing a line like this. Now if you notice here, now this has given me 4 compartments. I am going to name them. This is group A, this will be group B, this will be group C, this will be group D. So this is the COPD ABCD assessment. Now tell me students, out of these 4 groups, which will have good prognosis? It is generally group A, because patient is having less symptoms, less exacerbations. Which will have very poor prognosis? It is group D, because patient is having more symptoms and more exacerbation. The primary goal of this classification is to identify the patients belonging to group D and to concentrate on them effectively, because these patients have high chances of mortality. Let us see the treatment options. If it is group A, I can start a bronchodilator. A single bronchodilator will be sufficient, because this is not that significant disease. So what will be the bronchodilator? Initially I can start with short acting bronchodilator, either SABA or SAMA. Now if the patient is belonging to group B, here definitely I should give a long acting bronchodilator. I should give a long acting bronchodilator. What will be that long acting bronchodilator? Either LABA or LAMA. Either LABA or LAMA. Whereas in group C, I should give the most preferred bronchodilator. I go for LAMA. I go for LAMA. Now in group D, I am going to start LAMA first, the most preferred bronchodilator. This is the group that I should be very careful. And even after starting LAMA, if patient says that, doctor, my symptoms are not decreasing, so what will you do? If patient symptoms persisting like that only, so he is telling that not even 10% of symptoms have decreased. So if patient symptoms are persisting like this, Now what I do is, to this llama, I add another bronchodilator called as LABA. Now on the other hand, you have started LAMA. Now this group D, patient will have more symptoms and also more exacerbation. One cause for exacerbation has observed in the studies was, patient might be having history of asthma. See, in the childhood he might be having asthma. Later he has done smoking and now he has developed COPD. Now that asthma tendency might also be responsible for exacerbations. Now if there is history of asthma or blood eosinophil count, indirectly if by you can see blood eosinophils, if there are more than 300 per mm cube, in this group of patients the main issue might be for recurrent exacerbation, that asthma component. So what I am going to do, I am going to give the effective asthma treatment, that is combination of LABA plus ICS. I am going to start LAMA. If symptoms persistent, LAMA plus LABA. If history of asthma or blood eosinophils are more than 300 per mm cube, here I am going to prescribe LABA plus ICS. Apart from this, in this group you should use your all treatment options. So you can consider roflumilast, and also azithromycin prophylaxis. It is just, this is a group where the patient requires utmost attention. That's why I am using all the possible options. This is the new COPD ABCD assessment. Based on patient symptoms and exacerbation history, we have classified into 4 groups, A, B, C, D. In that group D requires most attention and I am going to use all my options. So we are going to start LAMA, and depending on the patient's response, LAMA plus LABA, LABA plus ICS, and you can also consider roflumilast, azithromycin prophylaxis. Now let us see a case scenario here. There was a 60-year-old man with COPD. He is brought to an emergency room by an ambulance crew that has been giving oxygen by mask. 3 days ago he noted his sputum has changed in color and increased in amount. Any COPD worsening, it is called as COPD exacerbation, students. Now this patient has worsened, resulting in emergency room. On arrival he is conscious. There are diffuse expiratory wheezes. ABG reveals pH 7.31, PaO2 56, PaCO2 60. False regarding the management. Administration of IV steroids. Because it is exacerbation, you should give IV steroids. Nebulized beta 2 agonist. In exacerbation, the bronchospasm, you can counter it by nebulized beta 2 agonist. Mild hypercapnia can be permitted during invasive mechanical ventilation. This is also true. Actually, in COPD patients, their body is used to some amount of hypercapnia. No need to immediately bring down the CO2 to normal. Now patient CO2 in the question is 60. No need to bring it to 40 immediately. See, if you want to bring CO2 to normal, you have to aggressively ventilate. If you aggressively ventilate the patient, he will develop pneumothorax, and moreover patient's body is already used to some amount of hypercapnia. So that's why in the mechanical ventilation of COPD, you are not bringing the CO2 down immediately. You are permitting some amount of hypercapnia to happen. In COPD, hypercapnia is permitted. Mild hypercapnia is permitted. No need to worry about it. This phenomena of permitting hypercapnia is also called as permissive hypercapnia. You yourself are accepting hypercapnia. You yourself are giving permission for hypercapnia to happen. So this phenomena is called as permissive hypercapnia. Whereas the first option, NIV is contraindicated. See, this is a type 2 respiratory failure. Patient is conscious. He is a COPD. What should be started? NIV. NIV is contraindicated is the wrong option. Answer A. This is regarding COPD management. We have discussed the various treatment options, ABCD, the grading of dyspnea, and also a clinical case scenario. And you should know how to differentiate COPD asthma clinically and also with help of spirometry for your